Welcome to this episode of Living Healthy. I'm Dr. Barton Bishop, Chief Clinical Officer of Sport and Spine Rehab, and we're here to help you make sense of a nonsensical healthcare world. Also with us is my colleague, Dr. Jay Greenstein, the CEO of Sport and Spine Rehab.
Hi. It's great to be here today. I've been really looking forward to this program today. We're getting into the time of year where it's all about spring sports. The kids are getting out, they're getting involved in sports, and plus there's so much talk these days about the injuries that have occurred with our Washingtonian athletes. Our Steven Strasburgs, our Fred Davises, of course, RG3. And so with us we have a nationally renowned surgeon, Dr. Jim Gasho. Dr. Gasho, he went to Stanford University, played baseball for Stanford, then went on to medical school at Georgetown and did his orthopedic residency at Georgetown as well. We've had the great privilege of working with Dr. Gasho, co-treating many patients, done an outstanding job, and we are so thrilled to have you here today.
I'm glad to be here.
Yeah, thanks for coming.
Sure.
So tell us about some of the things that have been happening with these Washingtonian athletes, namely Steven Strasburg. Maybe you can tell the folks at home a little bit about why his injury occurred.
Mr. Strasburg has a very interesting pitching motion. So he brings his arm down, he basically whips the arm through. His pelvis is moving forward first, leaving his arm behind, and as he brings that arm through a little bit later and a little bit more slowly, it puts a lot of stress in the middle part of his elbow. With as hard as he throws the ball, it led to this injury of the ulnar collateral ligament.
Does that help him throw harder?
Well, the whip is just his technique. I mean, that's just how he throws, how he learned to throw, and what was more comfortable for him. It's not the classic mechanics for throwing, but it's just what works for him. I think if a pitching coach were to get him at age 8, they'd change his style completely. But that just was what worked for him, and he was successful with it, and no one wanted to mess with it. But it did lead to his injury.
Yeah, it seemingly did. So there's at this point, he's been injured, he's been repaired. No one in their right mind is saying, all right, let's start over, Steven. Let's see what we can do and do a different motion with you.
Well, I would expect that there would be pitching coaches who would want to tweak it a little bit and try to take a little bit of the stress off of the repair that he's had. And I doubt that he'll ever come out as an overhand thrower. But I think it would behoove him to be a little bit more technically correct in his throwing to try and preserve what he has and not go through a second injury.
So for the folks at home, just do me a favor, show everybody where the ulnar collateral ligament is in the elbow.
Well, the ulnar collateral ligament's on the middle side of the elbow, and if you ever watch Strasburg pitch, as he comes through here, he's putting a tremendous amount of force, kind of stretching open like a book, the ulnar side of the joint. So on the middle side here is where that ligament is. And when he tore it, it was just forced so far back that it just resulted in the ligament tearing. I mean, it's an injury that had been occurring over years, but it finally went on that one pitch that you show.
So obviously very, very painful for the athlete. Also, now he's got an unstable elbow. Tell us a little bit about the surgical repair. What is the Tommy John surgery?
Well, Tommy John was a pitcher back in the 70s, and the surgery was named after him. It was performed by Steve Job first, and Dr. Job did this back in Los Angeles. He was the guinea pig and given a 1 in 100 chance that it was going to work, and as we all know, the history shows us that it worked very well, and he had a number of wins after the surgery. But what they really do is they recreate a new ligament. You can't repair it. It's been too attenuated. Over the years, it stretches out, and when it finally ruptures, there isn't much ligament there to repair. So they recreate a ligament. You take a tendon from some other place, and you weave a hole into both bones that make up the elbow, the humerus, and then the ulna. You create some drill holes, and you make a figure of 8, and you lasso the thing and suture it back to itself, and you have your new ligament.
Now, some people say this is stronger. There's all the people that are like, okay, now this ligament is stronger. He should be even better, potentially.
Well, I think that's a misconception. I really think that what happens is that as I mentioned, the course of the few years that it takes to wear down the ligament and finally rupture, the ligament is loosening, and the pitcher is throwing less and less hard. And so once they're repaired and reconstructed and then rehabbed, they're throwing back to what they would have thrown before they started to have an injury. So it's not really that they come back stronger. They go back to the level that they should have been at the beginning.
So it's not like this tendon was perfectly healthy and normal and then just ruptured. The tendon was on its way to rupture.
That's exactly
over years
right.
and years and years.
Exactly, and especially in this particular case. It's an overuse injury that finally gives way.
Yeah.
So are there ways that pitching coaches and or athletes and or parents can kind of see those early warning signals early on and maybe prevent this from occurring in the first place, where that ligament tears completely, or where there's so much overstretching or degeneration that they can't pitch anymore? I mean, what can parents, teachers, coaches, trainers do at home to help prevent it?
That's exactly right. You look for the warning signs. The warning signs are going to be elbow pain, especially middle-sided elbow pain. You can also just look at a player and the way they throw and know that they're going to be a setup for this type of problem. Your submarine pitchers, your sidearm throwers, people that throw a lot of breaking balls are going to be those that are more subject to this type of an injury. It's going to be your overhand throwers, or ones that have a more modern mechanics, that are going to be less subject to the injury.
Sure, that makes sense.
A lot of people talk about Greg Maddux as someone that had kind of perfect mechanics, never
That's
really
right.
had an injury. I mean, is this something that our audience, they have their 5-year-old Johnny and Billy, and they want to teach them to be a pitcher? Should they go out and YouTube a video of Greg Maddux and emulate that, as opposed to a Steven Strasburg?
Oh, I think so. I think that you really want to try and stress good mechanics when you're with your young athletes and your young throwers. The truth is, though, the ones that are really good and that have unique motions, they're off for something a little bit different. The ball comes from a different site. It's harder to pick up. It's not as it has more movement to it and more motion. So you see why Strasburg's effective. Not to mention the fact that he throws so hard. Yeah. It's because it's harder to pick up the ball from where he throws it. So you want to foster a good technique, but then again, if you're a machine and you're just out there throwing batting practice, guys are going to tee off on you. So there is going to be some benefit to having a unique motion.
So a lot of hoopla, right, about shutting him down, but that's past. So now we're going to talk about this year. Everybody's getting pumped up for the season, me included.
Got some attitude.
Yeah, got some attitude, exactly. Tell us about what we can expect from him this year. I mean, from what you've heard and what you know about the injury, I mean, what are we going to get at him this year?
You're going to get Strasburg right back.
All right.
Yeah.
I don't think there's going to be any downside to him. In fact, I do agree with them resting him. And as hard as it was for me to watch, I was at that first playoff game, as hard as it was to watch them lose, I have to agree. I think that's part of the reason that these guys get re-injured, is that they get back in too soon. Yeah, and it took a whole lot of nerve on somebody to keep this guy out. And I agree with the decision, and I think you're going to see Strasburg 100%.
So speaking of going back too soon, everybody knows what I'm going to ask next. Tell us about RG3. You saw the initial injury against the Ravens. What are you thinking in your mind? And then what about him during that playoff game against the Seahawks? Him going back in after he was injured. What was going through your mind?
As soon as I saw the injury, the first thing out of my mind was, God, he's ruptured his PCL. He had such an extreme hyperextension injury, which if you hyperextend the knee, generally ruptures the PCL. The anterior cruciate ligament, or the one that he in fact did re-rupture, is generally a flexion injury, or it's twisted, or it happens in flexion, not an extension. And there was clearly, if you see the tape, a hyperextension injury. So I thought he'd torn his PCL, but there was no doubt in my mind that injury led to a rupture of some ligament. There was no way you could have that much force and it to be a sprain, which is what we were told initially.
Sure.
Yeah, I mean, initially I think they said it was a grade 1 MCL sprain, and for those of you who don't know, we're talking about 3 grades of sprains. 1 is not so bad, 2 is it's a little bit torn, and 3 is completely gone. In this point, we're talking about, a grade 1 MCL sprain is what they said.
Exactly.
So he rests for a couple weeks. He comes back, and he is a shadow of his old self. I mean, he looked like me running out there.
He's barely able to do it. I mean, you got to give the guy credit for his heart.
Oh, yeah.
There was no question the guy was playing with his heart, but he clearly didn't have the physical skills, and it was sad to watch him try and make it through those games. And from my standpoint, thinking, what are you guys doing letting this guy play? I don't care how much he wants to play or tell you he's fine. He just wasn't ready to do it and really shouldn't have been out there.
Yeah, I don't think there was one fan out there they're not orthopedic surgeons or physical therapists or chiropractors, but there wasn't one fan out there who wasn't saying the same thing. Yeah. So the whole thing was just kind of bizarre. But where's he going to be this year?
Well, the injury that is sustained is fairly dramatic, and the fact of the matter is he's already has undergone that injury once before and has already had 1 reconstruction. In general, second go-around never works as well as the first. Now, you got to admit, this kid is an incredible athlete. He is not your average person.
And you talked about his heart.
And I'm talking about his in general physical condition, his skills, his work ethic, all the things that make him RG3. He's really got, if anybody's going to have a good chance to come back as well as you can and as good as he was before, like Adrian Peterson, I think it's going to be RG3.
Okay, so Redskins Nation is even though we have an attitude, I mean, you know they're always on pins and needles. Likelihood RG3 gets back at 100% week 1. I mean, just from this. Look, this is a larger conspiracy than Watergate. I think in DC is what's wrong with RG3's knee and where's he going to be?
Well, you know, I've heard just anecdotally that he's on schedule and that he's rehabbing it already. I have a hard time believing that this guy's going to be 100% this season at all. Mm-hmm. I really do. I mean, he had surgery after the season. Yeah. I mean, he's going to have not that much time to rehab. He's going to be very, very subject to re-injury, and I think they're going to have to really bandage this kid's knee and really protect him in order to keep him playing for them this year. I have to admit that I'd be more in favor of him not playing this year.
Yeah, I was going to ask that question. I mean, maybe they should really hold him out until he's 100%. I mean, you know, we talk about return to play criteria. You'd want him to be at 100% so he doesn't go down that same road again.
With my recreational athletes, the weekend warriors that rupture their ACL, I don't let them ski for a season. Mm-hmm. They're 9 months out before they go back into competitive sports. And we're not talking about NFL competitive sports.
We're talking about us.
I'm talking about us.
Yeah.
And I 6 months, 9 months, and that's just to go back and ski and play basketball down at the Y. That's not playing NFL football.
Sure.
I really think he's at risk to play this season.
Yeah, you know, there's the whole thought that if the Redskins aren't going to win a Super Bowl this year, and you don't need to bring him back, if they don't have all the pieces in play this year, maybe it does make more sense to hold him out for a while until they can get back to the point where they have this team around them, so that
they have a quarterback that can play, obviously, also. I mean,
Cousins
he did a great job
What's
last
the worst
year.
case? He re-injures himself and his career's done.
And it's done.
Right.
That's right. And truth of the matter is, this is a matter not only of rehabilitation, it's just time. For that graft to ingrow and reincorporate it's going to be at its weakest point at 6 months. It's going to be 9 months before that has the strength back again to support all the sports that he needs to do. I think it's potentially a mistake to bring him back. Maybe he'll prove me wrong. I hope he does. But I think it's really a risk. I really do. I think rehab for the next 6 to 9 months, and you bring him back, especially as a revision or a redo of injury, because he has both ligaments. He has the lateral collateral and the anterior cruciate that were injured. Yeah.
You bring up great points, and the physiology that we can't see on the inside, that bone graft, what has to happen on the inside is really important, because you see him doing all these things on YouTube, you think he's ready to go, but the physiology we can't see, and it's just a great important fact that you're letting us know about and also our viewers. So we're gonna, when we come back, we want to talk about at least one more Redskin. We want to talk about Fred Davis and his Achilles tear. So folks, stay with us. We'll be back in just a few. And when we get back, we're going to talk more about injuries and also the injuries that you all suffer from as well. And we can get some recommendations from a world-class orthopedic surgeon, Dr. Gasho. Thank you.
Weight loss, it's one of the many ways to fight osteoarthritis pain. For more information on managing pain, go to fightarthritispain.org.
Welcome back to Living Healthy with Dr. James Gasho and Dr. Jay Greenstein. So we were talking about sports injuries, and we were talking about Steven Strasburg, elbow, RG3, knee. Let's talk about Fred Davis and his Achilles.
All right.
So he tore his Achilles. What causes this?
An Achilles tendon rupture in an athlete like that is what's called an eccentric load, which means that the tendon's going one way and the body's going the other, and it results in just a complete explosion rupture with two mop ends of the Achilles tendon.
Sounds fun.
It's fun to put back together. It's not so much fun for the patient, because the classic thing is they turn around to see who hit them, and there's nobody there.
Yeah.
And so that's the way you read it in the textbooks, and it's often what I hear in the office. Now, it's a pretty devastating injury. It's really limiting their abilities to walk and clearly to run, but it's an easy thing to fix surgically. But the recovery is long and arduous.
I remember hearing, years ago that, if that injury occurred to the athlete, they were not coming back. That was probably going to be the end of their career. So where do we stand with Fred Davis? I mean, what are his capabilities? If Strasburg is going to come back and be as good as he was, where's Fred Davis going to end up in all this?
Same thing. I mean, realistically, the issue is rehab. The surgery for Tommy John surgery is somewhat more difficult. It's only done well by a few people. It's not a well done surgery by a lot of folks. The Achilles, on the other hand, is easily done by most people. It's a 20-minute operation, really, to put it back together. But it's the recovery after that that's the hard part, and it's rehab.
That's our field.
We know a couple things about that, I think.
Just a little bit. Just a little bit. So this is an overuse thing often,
well,
though,
it can
right?
be. I mean, initially, in this case, for the highly trained athlete, it's not an overuse. But there are some prodromal signs for the average guy who's out there that his Achilles is starting to get a little tight, or his hamstring and calf's a little tight. Those types of things will give you some warning that you're set up for it. But oftentimes it just comes out of the blue.
I've seen this happen where they're just running and all of a sudden they just go down.
Exactly.
And are these patients reporting a tremendous amount of pain when the injury occurs?
No. I mean, they just get this feeling like they were kicked. Like somebody kicked them in the calf. It's not all that painful, really. Most people don't have a lot of pain with it. They have a lot of dysfunction, but not a lot of pain.
Okay. You mentioned overuse, Bart, and I think there's lots of folks out there that have lots of overuse injuries, but I'd like to talk a little bit about the pediatric athletic population. These kids are coming in droves into our offices. I mean, there's just so many injuries that are occurring out there. Tell us a little bit about your experience as to why there are so many younger kids coming into our offices.
Listen, when we were kids, it was one season, one sport, and you practiced 2 or 3 days a week at the most, and then when the next season came, you played the next sport. That's not what we have anymore. We have kids who are playing one sport, including my own kids, all year long, and then they don't just throw on one sport, they play 2 or 3 sports all year long. So these kids are doing way too much, way too soon.
I was talking with a guy, patient of mine just today, calling about his 12-year-old son, who thinks he has some heel condition called Sever's disease. Said his heel was hurting all weekend. I said, well, what did he do this weekend? Well, he played 3 soccer games on Saturday, had a basketball game on Saturday, and a lacrosse practice on Sunday. And I'm like, really? Oh, that's it? I mean, there was more hours in the day. Couldn't you give him a little more?
Right.
I mean, when I was young, and when we all were young, and I'm not that old, but it was soccer, and then basketball was a different season, and then golf was a different season, and so on. Why doesn't that happen anymore?
Because if you don't play all year long, you're not going to make the team. It's so competitive, and kids are practicing so much and have gotten so good so early that truly, if you just do the one season, one sport, you're not going to make your school team, you're not going to make the travel team. So you really are, I mean, you can choose to be a rec player, but if you want the high-performance kid or the kid that's going to get the scholarship for schools, they got to play all year long. It's just nature of the beast now.
I had a totally different situation. My situation is I have a extremely protective Jewish mother. So she only let me play one sport. That was it. I could only play one sport. That was it.
Never football.
Never football.
You get injured, right?
Safe. Right.
But I see a lot more kids coming in. Sever's disease, for all of you people, is just it's an overuse of a growth plate on the back of the heel bone, and it's pulled on with so much force with so many sports, and they don't get a chance to rest.
By that Achilles.
That's right. Yeah. That's right, because that's a growth plate area. It's an analogous thing to the knee when you hear of Osgood-Schlatter syndrome. And it's just a matter of an overuse. It's just too much. And what I tell all these parents is that what they need more than anything else is rest. Now, then the bargaining starts on, well, can Johnny do this, and can they do that, and how much of it is this? And the answer to that is, well, they can do what they can do, but resting it, therapy and anti-inflammatories are the way to go.
Well, the best part is it's the parents bargaining almost more so than the kids.
True enough.
I mean, the kids don't want to be in pain. They may want to play, but they don't like to be in pain. But you get those parents where they're like, okay, but can they just play 2 games this weekend instead of 4? That's less, right? That'll make them feel better.
How often do you run into that? I mean, where you've literally got to kind of set the parents straight and say, Johnny can't play this week. In fact, Johnny needs rest for a week, a month, the rest of the season. How often does that happen?
It has to. It's patient. Every individual patient. It depends on the level of problem and the parent's understanding of the problem.
Sure.
If they're really not getting it, then you have to give them a little bit more of a talk. But otherwise, I mean, most parents are out there looking at the best interest of their kids, and I think they're just being their kid's advocate.
Yeah.
And frankly, I think that if you tell them that they can, whatever they can manage, but if they call me up and say Johnny's not getting better, the answer is, did Johnny rest? And if they didn't, then the truth is that they just need to rest.
So what are some practical things that people can take out of this? Is playing, is there a certain amount of rest between seasons? If they're going to stick to just soccer, is there anything practical that people can take from this?
There's no data to support this. It's common sense.
Yeah.
It's that if your kid's able to handle it and they're doing great in school and they're playing 3 sports at the same time, it's hard to argue with they need to spend time resting. But if they're breaking down, if you're seeing more than one either stress fracture or a stress-related injury, Shin Splints, Seaver's disease, Osgood-Schlatter, I see much more tendonitis in a pediatric age group than I ever used to. Those are warning signs that they're just overdoing it, and they need to peel off a layer, maybe 2 layers, or take a month off. But it's really hard to get the kid to do it and the parent to agree to it too.
So for the folks at home, maybe you can help them understand the difference between an acute and a chronic injury. Physiologically, what's the difference?
Well, an acute injury is something that occurs, it's in a point in time, and it's generally very painful, it's very sudden, and it swells, and it hurts, and they're really disabled by it. A chronic injury is something that's a little more low-key, so to speak. It's a little less painful, it's a little less debilitating, but it nags. It sticks on for a longer period of time. And an acute injury can become a chronic injury, but it partially heals, it was partially treated, and it never quite gets all the way back to normal.
So the treatment of those things is different. The prescription by you, what you do, the amount of rest time, etc. Acute and chronic, they're completely differently treated.
Mostly. I mean, the acute injury, you really need to step back and to take away the offending problem and to try and rebuild from that level. From a chronic injury, there's a little bit more. You try and build up around what's already there, or retrain what isn't being appropriately treated, but you don't have to start from scratch.
What risk factors can the folks out there employ with their kids, or even themselves, but specifically their kids in this discussion, to reduce some of these acute and traumatic injuries?
Well, it's a matter of stretch. It's a matter of common sense and not overdoing it. And frankly, I don't think there is enough stretching that goes on. I mean, we don't preach enough stretching. I don't think they take enough time to do stretching and to do warm-ups. I think it's getting more prominent and more prevalent in our kids' age groups. But I think really warm-up is still key for the young person. Clearly for us middle-aged athletes, we don't have enough time to warm up, but we really need to more than the kids do.
Sure.
Because our ligaments and our joints are stiff. And let's face it, we're a little more stiff than our kids.
Stiff is the operative word. That's right.
Yeah, exactly.
And warming those joints up and warming those ligaments and tendons up will help prevent some of these overuse problems that we're going to see here in the spring.
Great advice.
Yeah, I mean, so speaking of that, you mentioned a buzzword to runners, and that's shin splints. So running season is upon us. We had the National Rock and Roll Marathon last Saturday. The Cherry Blossom is coming up. What are shin splints?
All right, as a guy who's done 8 marathons, there's no running season. You run all year long. It never stops. So, the runners are going to have problems any time of the year. I mean, a little more cold out is going to be a little bit more, lead to a little more problem. But shin splints is just an overuse or a stress injury to the tibia. It's to the lower leg area. It's to the front part of the lower leg area, and it's fairly painful. I mean, it can be fairly debilitating. It can lead from the standpoint of just a little bit of an annoyance when you're running to the point where it's downright achy when you even walk. And it's just a degree of how involved it is and how far you've let it go. So.
And then what? So can it lead to something significant?
Well, you can lead to a stress fracture. It absolutely can. It's a prodromal to a stress fracture of that bone. And it has to do with either an incorrect running technique, Flat feet lead to it. Some bad shoes. I mean, those types of things can really lead to shin splints. And that's another one that therapy is the way out of it.
I think that's been our experience in our practices, and we've just seen it over and over again. The folks that come to us early when they have these conditions, we're able to fix rapidly. But the folks that have had this thing going on long periods of time, ultimately, we have to refer them out for imaging, and next thing you know, we find something we don't really want to see.
Yeah. Once it's been there a while, that's a difficult problem to get rid of. Mm-hmm. And it may just be that the running technique has been off for such a long time, it's tough to retrain that, or that it's getting to the level of a stress fracture. And so early recognition and early treatment are very, very helpful. I mean, treatment may just be rest. It doesn't necessarily mean formal physical therapy, but early treatment in the form of resting, icing, and anti-inflammatories, the so-called RICE, is certainly helpful. Sure. But oftentimes physical therapy plays a role in this one.
Sure. So it's very interesting because folks out there's lots of problems, lots of injuries, acute and chronic. How do they know a good orthopedic surgeon? I mean, people, there's all this information out there online. How do they know when there's a really good surgeon like yourself? There's some other really good surgeons nationally. How can they find folks like you? What's the best way to determine who's good and who's not?
Well, nowadays the internet gives you all that information. My daughter looks on my reviews and she reads them out.
So reviews are good?
Yeah, no, reviews I think are really helpful because you get a good sense of what the person's like. I mean, you got to get somebody who's going to listen to you. You got to get somebody who's going to take your opinions and what you say into account. If somebody's just has you pigeonholed and they're going to be dogmatic about what they tell you to do, they're not the person for you. You need somebody who's going to listen to what you have to say, what your problems are, and tailor a treatment to your specific needs.
That's very wise. We just attended a research conference this past week, and they talked about outcomes are tied directly to patient preference as well. So what you just said is just amazing advice, very, very timely advice. Anything else you think our viewers need to know about working with an orthopedic surgeon or what to expect if you have a surgery? I mean, post-surgical rehab, how fast they can get better? I know it depends on the case. But
you need somebody who really is going to be responsive. If you can't get a hold of them, if they're spending 30 seconds with you in the office, I understand we have this bad reputation of making people wait to be seen, but that is unfortunate that does happen, and it happens to me sometimes too. But truly, if you get their attention once you have it, and they're listening to you, and they're treating you based on you rather than based on a syndrome or a type of problem, and listening to what your problems are, and post-operatively are responding to you, that's the type of person you want. I mean, they may be the best surgeon on the planet, but if you can't reach them, they're not any good for you.
Sure.
And one of the things we've always enjoyed about working with you in particular is that there's that phrase, when all you have is a hammer, everything looks like a nail. And a lot of orthopedic surgeons tend to just do surgery, injections, drugs, and you don't do that. You look at the patient on a broad scale, and I think that's kind of what you're getting at with this orthopedic surgery, picking the right one that's listening to you and making the treatment recommendation that's right for the patient, not what's right for the doctor.
That's right. I think finding somebody nearby is helpful too. I mean, you don't want to have to travel too far.
Yeah.
I mean, that's the other thing. People will go up to New York to have their surgery, and if they have complications, they don't get on a train and go back to New York. They come see people locally.
Yeah, sure.
So finding somebody that you're comfortable with locally really helps too.
Well, speaking of local and a great surgeon, how do they get in touch with you?
They can reach me in my office. Area code 301-986-1701, but I also have my email, which is jagasho@msn.com.
That's great. By the way, what's your PR in the marathon?
2:39:36.
Wow.
Not bad. That's great stuff.
That's a few years ago.
Well, folks, thanks so much for being with us today. It was a great show. I was really looking forward to this. Got a lot of great information. We look forward to seeing you next time on Living Healthy. We're going to have a great show for you, so come back and see us. Thanks so much.